Hello everyone, welcome to today's webinar where we're covering paper 3 of the 4 papers in the standards for people with cystic fibrosis. This paper is titled Recognizing and Addressing CF health issues, so specific CF health issues. My name is Kevin Southern. I'm a professor of child health in Liverpool, and I am the current director of the Standards of Care Committee. And today I'm joined by colleagues from across the globe, which is super. So I'm first of all Pierre Regis.
Well, thank you, Kevin. Good morning, good afternoon, good night, everyone. So my name is Pierre Regis Burgel. I'm professor of respiratory medicine at the University of Paris in France.
And also by Peter.
Good evening, good morning, and good afternoon. I'm Peter Middleton. I'm a professor of respiratory medicine in the University of Sydney.
And finally by Eddie.
Good evening, good afternoon, and good morning. Start off with that. I'm Eddie Lando. I'm a consultant clinical psychologist at Schneider Children's Medical Center in Israel.
Super, Eddie, thank you very much. So Eddie, Peter and Pierre Regis were all are still members of the core committee of the Standards of Care and were heavily involved in all the papers, but have joined me today to talk about this paper. In some regards, this paper is more aligned to the more traditional standards of care papers that have been produced by the Society over the last 20 years. But there's a lot of information in this paper, a lot to get through over the next hour. And it is somewhat different to last week's paper. So last week's paper was around establishing and maintaining health. And we had some interesting comments last week. We had comments around, well, isn't this just common sense advice for everybody? And, you know, to some degree that's true. But I think the unique challenges of doing this with people with CF and their families really sets our condition aside, and I think that the topics covered last week were innovative and really exciting. But we have to face facts that people with CF do face unique challenges, complications, and issues which are really characteristic of cystic fibrosis, and we're going to cover that over the next hour. We start in all these webinars by highlighting 3 key messages, and to be honest, there could have been many key messages from today's paper, but the 3 key messages today, and I can probably post these in the chat for people, but the first key message is a proactive approach to the identification and treatment of airway infection and inflammation remains a cornerstone of CF care. And we'll come on to that and we'll discuss that in more length. Secondly, the complications that people with CF face are unique and challenging and require a consistent multidisciplinary commitment, as well as collaboration with specialists outside the direct CF team. And the final key message that we highlighted was that the mental health challenges for people with CF are also unique, and a CF psychologist should be embedded within the CF team and work holistically to promote improved quality of life through education, prevention, screening, and intervention. So we'll expand on all of those, but we do this every webinar, and I'll repeat those at the end of today's session. Just to recap briefly the methodology. So we had the core committee and we've talked about them, and the core committee identified authors for each of the sections, and relatively constrained sections, but still a lot of literature review and information to put in those sections, and really some tremendous sections in this paper. And I recommend reading this paper. So it's great that you've joined us today for the webinar. But what we're doing today in the webinar is reflecting on the paper, thinking about the key messages, what's different now to previous standards of care. So really, listening to this webinar should be added value to what you've already got from reading the paper. It doesn't substitute reading the paper, and at the bare minimum, but I would recommend reading the whole paper. But at the bare minimum, you should look through the statements, and there are statements that have been developed. So we ask each of the authors to produce 2 or 3 statements for their section, and we review those statements, and then those statements went out for a wider review amongst stakeholders, and we get comments back, and we see what level of agreement we have for those statements. And this, because at the moment we don't have a very robust evidence base to make definitive statements, and I think for this paper we probably have more statements than for any of the other papers. That's true, isn't it, Pierre-Régis? And actually, we got lots of really helpful statements coming back, giving us feedback, and we changed quite a lot of these statements, Pierre-Régis, following that. It was quite an involved process, the Delphi methodology for this paper.
Well, indeed, Kevin, I think the methodology was really original. And it was really helpful because we were writing our sections, and it's just a very constrained format, as you said. You have a section. I remember writing the section on exacerbations, for example, and you have like 20 lines to write on exacerbations, and then you develop a statement. And it's very important to get feedback from what you would call the audience or our colleagues, because it helps us refine the statement and refine the overall text also, and make sure that we don't forget some aspects of the disease.
Absolutely, and often the comments that came back were, can you be a bit more definitive about this? Can you tell us, well, you tell us to do this investigation, but can you say, do we do it every year or biannually? And we don't have the evidence base to be able to make those really categoric statements. So there have been comments that some of the statements are maybe not as clear as they could be, but that's because we're trying to highlight issues, and we want you to read through these statements and you go, well, are we as a team doing all these things? And if we're not, why not? And think about and discuss them amongst yourselves as a team, because the playing field is changing. Things are changing very rapidly in our field, and we had an interesting question after the last webinar, which was around. Oh, sorry, I've just posted the wrong thing. Actually, sorry. Trying to do 2 things at the same time, which is definitely not something a man should do. So one of the questions was, how are centres dealing with long-term PPI use, and how are they identifying patients who no longer need it? Now, within these standards, we didn't feel ready to really explore cross-infection again. So the standards, the cross-infection standards that are well established over 10 years ago, still really pertain to people with CF. And actually, people with CF were quite resilient during the pandemic in many regards, I think, Eddie, because they were quite used to the idea of cross-infection and the idea of wearing masks, for example. And I don't know whether that was your experience, Eddie.
Yeah, well, just 2 things. Just going back to what you said about the statements. Even maybe not everything is evidence-based, but I think they're very sturdy guidelines. And we've had enough people, experienced people all over the world looking at these statements. So it's based on also clinical experience. So it's something just to fall back on to have a look at the statements. Regarding the corona, what I noticed with our patients, and I've spoken to patients also, from other centres as part of the co-chair of the mental health working group in the ECFS. So I've spoken to my colleagues. Is that actually the CF patients was quite a relief for them. They felt that now they could be understood by healthy populations, that normally they went around with masks and prevented. They could actually teach other people how to actually cope with a pandemic, and it actually strengthened them, and they felt actually more part of the wider community. That was my experience.
But now the pandemic's finished, and we're very much in Europe. I think over most of Europe, we've moved back to a situation that was very similar to before. But there is some conflict amongst centres. Some centres insist on mask wearing for patients and sometimes for staff. In the US, there's much more gowning up and wearing gloves for outpatient consultation. So there's quite a lot of variance across the globe. And I think this is something that we will look at a bit more as a standards of care committee when we explore models of care moving forward over the next couple of years. So back to the paper. So the paper, there was 4 main topics or sections to the paper, and the first section was on airway infection and inflammation. Then there was a section that reviewed some of the specific complications. There was a section on supporting mental and emotional well-being, and there's a section around when things get really quite challenging. So we'll cover those 4 sections. With regard to identifying and addressing airway infection, there was a really nice section written by a group who reflected on chest x-rays, respiratory function testing and so forth, and clearly outlined that those remain important modalities for people with CF. There's an excellent section on inhaled mucoactive agents such as Dornase alpha and hypertonic saline, and these are drugs that we had really quite a robust evidence base prior to CFTR modulator therapy, and that's reiterated in this section. But they also allude to the fact that we need to be revisiting this, and studies are ongoing. We talked about this last week. So for me, possibly the section that I found most interesting, and has actually made me and the team I work with reflect on our practice, is around surveillance for airway infection. And Peter, as an adult physician, I know the post-modulator age has been really quite a dramatic change, I think, for many adults with cystic fibrosis, some of whom have become non-productive on this new therapy, which is obviously great, but problematic from sample collection.
Oh, absolutely, Kevin. And the difficulty is that so easily in the past we could just say to someone, here, give us a sputum sample, so we know what was down there. But nowadays it's a much more difficult sort of concept. But importantly, when they do have exacerbations, often the old organisms are still actually there. Yeah,
Pierre-Regis, this is a sort of theme that's coming through, is airway infection. Although the number of positive culture growths is reducing on CFTR modulator therapy, the airway infection is still there, and it might be over time that we see a different sort of characteristic of the airway infection, and we really need to be on our toes. And there's nice sections in this on this topic covering NTM, which is fairly novel, and also a section on fungi. Did you want to make a comment on that, Pierre-Regis?
Well, Peter just said that how difficult it is to get samples now from patients. And I think it's important we keep trying. And the surveillance of microbiology in CF patients, I think, is still very important. And as Peter said, when the bugs are already there, when there is chronic infection in people with damaged lungs, usually the bugs do not disappear. We don't really know about acquisition of new bugs under CFTR modulators. and whether it's still valuable to do, for example, eradication of Pseudomonas. So the only way to know is to search for it. And it's not that easy because people don't produce sample on a daily basis. When they're asked to produce a sample during a visit, many times they don't produce a sample. And even when you try to do induced sputum, sometimes it doesn't work. So I think it's important, but I'm not sure I know how to get a sample for every single patient, at least during the visit. And then maybe there's a so-called windows of opportunity. So when people have an exacerbation, they should produce a sample, or when they exercise or when they do physiotherapy, they should produce a sample.
Opportunism is really important. In pediatric practice, we've been very familiar with non-productive patients for decades now, and we do oral pharyngeal sampling, either nasopharyngeal suction or a cough swab. But I think it's quite clear and is outlined in these standards that induced sputum gives a layer more sensitivity and is a more reliable sampling technique, but it's actually logistically difficult. You can't do an induced sputum on every single patient coming through a clinic because it takes time. So the guidance suggests doing this at least once a year, and in pediatric practice that's can be quite challenging, particularly on smaller children, and we weren't able to really put an age limit on this recommendation, but we kind of felt that people should be discussing this amongst themselves as a team and moving forward in this regard. So I think that's quite a change in attitude towards airway surveillance, which is important. The next section is really excellent, in my opinion, written by Margaret Rosenfeld, Alan Smith, Giovanni Tacchetti, and Claire Wainwright, around approaches to antibiotic therapy. And antibiotic therapy has been and remains kind of a key element of keeping our patients well. But these authors, they highlight the lack of evidence that we have with regard to specifically whether we should have patients on antibiotics all the time in a prophylactic manner, whether we should be undertaking eradication, or whether we should be suppressing chronic airway infection. They kind of outline that for Pseudomonas aeruginosa, there is a good evidence base, and this remains pertinent even in a post-CFTR modulator era. So for Pseudomonas aeruginosa, they're quite dogmatic, really, that this is something that we should all be doing, and that's reflected in the statements. But for other CF pathogens, they've said that a proactive approach is reasonable given what we've known about the history of cystic fibrosis, airway infection, and keeping patients well. So I felt in the end, and you'd remember those statements were quite tricky, Pierre Regis, to sort of hone down on, but I felt quite comfortable with those statements at the end, and obviously the vast majority of people did, because we got consensus agreement on them. But how did you feel about that?
Well, I think from a doctor point of view, it's very reasonable. Then the patients have a tendency to stop treatment, especially when we're dealing with chronic treatment like inhaled antibiotic, nebulized antibiotics. And then I think we should be very careful, and probably there are different kind of patients. It's very different if a patient under CFTR modulator has an FEV1 of 100% or whether he has an FEV1 of 30%, because what you try is to prevent deterioration in lung function, deterioration in health status. And you don't know what's going to happen with these patients who have low lung functions under CFTR modulators, where they will be in 10 years. Will they go to transplant? Well, so I think we have to remember that the treatments, the CFTR modulators, they were studied in patients treated with the usual standard of care, including antibiotics. And we have to be, I think, very careful, especially for the more severe patients.
That's a really good point, actually. And Eddie, it's been really difficult to, well, not difficult, but it kind of like trying to put over the message that this is a new pathway for people with CF. This is not the end of the CF journey, because that many of them are feeling really quite transformed by the new therapy. Yeah, and trying to put that over, that this is not the end of the journey, that we need to still work together and be diligent, is when they're all going, oh yeah, no, finish, I'll just take these tablets, and yeah.
I think that's also regarding to induced sputum, physiotherapy, adherence to any treatment. It's like, well, everything's fine, I feel better, so why can't we enjoy this freedom? Why are you hanging another burden of treatment over us? And I think this is one of the complexities, and we'll talk about it more later, but of trying to fine balance of both celebrating and enabling them to live a normal life, but on the backdrop of remembering that with the modulators and with the treatments, it's not a cure, but it's definitely a way to live a more fulfilling life, but that one has to still be careful and take precautions. And when they do need the antibiotics, there is some form of disappointment or a feeling, oh, we're going to go all the way back again to having to take medication all the time or antibiotics all the time. And it's holding them in that space of, no, it's just temporary, and it's just to strengthen and to reinforce. It doesn't mean it's forever. So it's a very fine balance, and I think it's very important to address the hope and also the reality of the situation, that there is still struggling with a chronic disease, but with a much brighter future. I think that's the way to look at it.
Yeah, brilliant. And we discussed this a bit in the last webinar, Eddie, around sort of working with the person with CF and their family to sort of identify like what their hopes and aspirations, what their aims are, and how do we get to there, and supporting them and respecting their choices. But many patients are not happy to stop any therapies because they feel very comfortable with where they're going. So they need an evidence base to sort of be able to say, well, actually it is okay to stop this nebulizer or that nebulizer. So we need to respect that.
I think there's two groups. There's one who don't want to stop, they want to have the security, and the other group who want to just give up everything. We have many parents who don't want to continue physiotherapy for their children because they think, well, everything's fine. So one has to be very attuned to what each patient brings and how they see the future as well.
Listening is important.
Listening.
We're all good at talking, not so good at listening. Pierre Regis?
Yes, Kevin, just wanted to say also that it's always this discussion about continuing treatment, stopping treatment, but life is a journey. So sometimes you stop treatment at some point and you restart it later on, or sometimes you continue treatment and then you decide to stop it. So no decision is completely definitive in this area, I think.
That's a very good point. And outlining that you're keeping that door open to revisit treatments in the future is really important. So that takes us on nicely to the next section, Peter, which kind of outlines some of the conditions that we're very familiar with as CF physicians. I mean, obviously most of us are pulmonologists. We all feel very comfortable with the airways, but then when it gets outside the airways, sometimes some of us are a little bit more outside our comfort zone. But we're all very familiar with diabetes. We're all very familiar with liver disease, CF-related liver disease, and to some degree bone disease. And we still, Peter, in this post-modulator age, need to be attuned to these potential complications and sort of surveying for them and responding, recognizing them and responding appropriately.
Absolutely, Kevin. And the complication is that over the next few years, we'll see whether the incidence of diabetes gradually reduces as people are healthier and they have less inflammation, less infection. But concomitant with that will be the problem that, in fact, CF liver disease versus modulator-induced liver disease could well be a complicating factor. So there's still a role for watching and checking to see if any of these complications continue to be a problem.
Yeah, absolutely. This is going to be an area that we're going to need very careful monitoring over the next 5 years. But you might expect, if the modulators are at a cellular level are correcting the defect, that things like diabetes and CF liver disease will become less prevalent. But we don't know that, and we can't assume that. And there's a lot going on in the diabetes world, a lot of really exciting advances that as a community we've tended to sort of be slightly one step behind our diabetes colleagues, but I think a lot of the work with regard to feedback loops and so forth is really exciting, and we need to be on the ball to make sure that our patients enjoy those developments in that field. And it's kind of highlights why we need to really have good relationships with non-CF specialists.
100%. And the difficulty is that CF diabetes is really quite unusual in that it's insulinopenia, but also with all the resistance from all the chronic infection. So it's sort of like halfway between type 1 and type 2.
Yes. So that partnership working needs to reflect on that unique characteristic and it's quite similar with CF liver disease in that you can have pretty pronounced cirrhosis but maintain the functions of the liver for a long time. And so portal hypertension is, Pierre-Regis, quite often a major sort of feature of CF liver disease, more so than you might anticipate.
And you're right. And we don't know much about the effects of CFTR modulators in organs outside of the lungs, including the liver and the pancreas, because we know some things. We have animal models, we have human studies in people with these complications, but then the exact relationship between organ damage and ion transport is unclear. I mean, when we restore ion transport in the lung, we get rid of mucus and the patient go better. But there are still structural damage that do not disappear. And I'm quite sure that in other organs, it's the same. And for now, we didn't see resolution of liver cirrhosis with CFTR modulators. We didn't see male infertility disappearing. So the relationship between organ damage and ion transport is really complex and might be different in each organ.
Absolutely. And possibly perspectives have changed a bit now as we're on this new journey. We've seen the overall data on life expectancy has really increased dramatically over the past 5 years, and that's a real epidemiological finding. So now our perspectives around bone health, particularly when we're thinking about our patients moving into an older age, and this will be covered to some degree in next week's webinar. But these factors of laying a healthy foundation are really important, and monitoring for bone strength. I'm going to just go over the sections on renal issues, just to say that read these, be aware of these potential problems that you might be causing your patients. The section on intestinal obstruction is really clear and very helpful. And then finally, there's a tricky section on early identification of cancer, with a view to the fact that there is a slight increase, a significant increase in apparent risk for people with CF of cancer. And Eddie, this comes into your comments before around, let's celebrate the intervention that we've had, that many people have benefited from with cystic fibrosis. Not all. We'll come on to that in a moment, but also make people with CF aware of these potential risks. It's a really tricky one, that actually, yeah.
Well, I think all of a sudden the perspective of the trajectory of their lives change for good and for bad. It's who am I now, and can I live a longer life, and what can I expect? What can I do? And then it's not only about living a longer life, but when a cancer diagnosis comes along with CF, which does happen regardless, but the longer you live, maybe it's not likelihood. It's at a double sting sometimes, and it feels like a betrayal sometimes, and it's very hard to manage that, and it's very important to hold the patient through that as well.
And Peter, I know this is something that has concerned adult teams tremendously, and that comes down often to some personal experiences of these really difficult presentations, and one of the important things that comes through is that people with CF should not miss out on routine screening that all people have, just because they're in the CF clinic and they're felt to be sort of looked after by the tertiary or the secondary team. But maybe some of that routine screening needs to be adapted for people with CF, maybe done at an earlier stage, and you've talked about that.
Absolutely. The difficulty is that colonic cancers are increased in people with CF, but whether that relates to the pre-modulator era and whether that's going to change with modulators, we still don't know. So it's one of those things of saying that we just have to follow and work out what is going to change and what's not going to change, but also recognise that the elephant in the room is that we still have 10-15% of the population are not on modulators. And what are we going to do about those individuals who haven't actually had this renaissance of wonderful new treatments?
Well, we maybe move on to that now, but just finally sort of reflect on the fact that the early identification of cancer is really important, and that's a great section, and that's something that will develop, research will develop in that area. I've no doubt over the next 5 to 10 years. So as Peter says, we need to keep a close eye on that. We did have a question related to the last webinar, but this takes us nicely into the next section, which Eddie led, around supporting mental and emotional well-being. And the question was, how do you console the non-eligible? This is interesting because initially when Ivacaftor came in over 10 years ago now, Eddie, there was a celebration. People who were not eligible for Ivacaftor were really glad to see people benefiting from that therapy. It gave them hope that things were moving in the right direction. I think it's very different now because the people who are not eligible for triple therapy are really in the minority, maybe 5, maybe slightly bigger percentage of all people with CF, depending on the country and the geography and the variant, the amount of F508del that is within a population. So that's tricky. I think Pierre Regis, sorry, Eddie, I'll just go back to Pierre Regis because he had a really interesting comment to me sometime around we should maybe not be thinking about eligibility anymore, but rather responsiveness. So do you want to enlarge on that, Pierre Regis?
Yeah, yes, of course. Well, if you remember how correctors were developed, they were found by screening on F508del expressing cells. So in the beginning, the understanding was really that CFTR correctors, which are within the triple combination therapy, were treatment mostly or even only for F508 people. And the first clinical trials, a large development, a study by Peter and others, these studies were done only in people with an F508. And then the approval for the drugs by regulatory agencies was in the beginning only for people with at least one F508 variant. And if you accept this, then the definition of being eligible is having at least one F508. But then we know that the FDA expanded the indications, and we know that there were efforts throughout the world, but especially in France, about finding non-F508 people responding to Trikafta, Kaftrio, so triple combination therapy. So eligibility is really something complicated, because if you're in Europe at the moment, you are eligible to modulators only if you have one F508. If you are in the US, you have 178 variants which are eligible. But this is not the only problem. The problem is being responsive, and probably even if you're not eligible in your country to a specific variant, the answer to what should I do because I'm not eligible is different if you have a responsive variant. So if I'm clear, if your variant is responsive, what you need is get access to the treatment. If your variant is a class 1 mutation, non-responsive to CFTR modulator, then you need all kind of research effort, gene therapy, mRNA therapy. So it's a completely different story. So I'm sure Eddie will comment on that. But what to say to a patient is different based on his variants and based on whether these variants are known to respond to CFTR modulators or not.
So that's interesting, Pierre-Regis. A sort of changing culture as to attitude towards. We really want to know whether these people have been tested. So the licensing is very variant specific, and that is an issue. But there's considerable costs involved, and so that's the situation that we're left with. It's really important for these families and for these people to know that the research is ongoing, and actually taking this research forward will be important for people who are on modulator therapy anyway, because we need another step beyond the treatments that we've given at the moment. Peter, you have a comment.
Yes, Pierre-Regis has done some beautiful work on the other types of variants that could be responsive to Trikafta or Kaftrio. But I think we also need to remember that there are a group of people who have toxicity from Kaftrio. And those are the ones who psychologically may have actually had a few weeks of wonderful improvement from Trikafta or Kaftrio, and then they develop the liver function abnormalities or some other complication, so really have to come off it. And despite trying to reinstitute the therapy, I've got a number of patients who actually can't get back onto it, because every time we try, even with relatively low doses, they get awful side effects. So they're the ones that I feel most sorry for, and psychologically I'd be very interested in any suggestions as to how to manage those people, because they know what they want and they'd love to have it, but unfortunately dying of liver failure is not necessarily a wonderful option, really.
Eddie, yeah.
I wish I could offer a wanted solution immediately, but I think, and also there are those who go on the modulators and also aren't able to continue because of the psychological, the neuropsychiatric side effect. A small percentage, but significant, also suffer from. So it's very, very frustrating. So what do you say? How do you cope with these people and also those who aren't actually eligible? And I think that again, one needs to provide space, not just by the psychologist, but by the whole team, to be with them in their disappointment and in their grief. It doesn't cure, but it's making the unbearable bearable by being with them and listening, reflective listening of where they're at. And then by enabling them to express what they're feeling and their hopes and what their dashed hopes, one could think of ways to try and ameliorate their lives, to make it better. What part of their lives have improved, even without the modulators, with the improved treatments? What things can one realistically expect for the future? What things can one appreciate? But also stay with the grief of what they're feeling as well, and provide the hope, because 25 years ago, when I started working in the CF world 17 years ago, no one would have expected such huge leaps in improvements in all realms. And this is something that I think that we need to provide them with a torch of hope, but being realistic with it. And I think it's very important. And I've learned this a lot, even with palliative care. And I get it's very hard with doctors where they see their patient who's not going to make it. It's very hard to stay with them with the reality of the situation, but it makes patients feel more lonely. So it is very important to be with them where they're at and listen to what's going on for them, because each person takes it differently. Not jump.
It is very variable, and my experience is that some of the families have gained great information from the CF Foundation website, where there's really accessible information on novel areas that are being explored. So that's a good route to sort of move them to give them the hope, as you talk about, the hope that things are moving forward. Pierre Regis?
Yeah, just a comment also on adverse effect with triple combination therapy, especially with Trikafta Kaftrio. What we don't really know at the moment is whether it's due to really restoration of ion transport, or whether it's an off-target effect of one of the molecules, especially elexacaftor, which is the newest one. And I think it will be quite interesting to see what happens with newer modulator combinations when they will be available, because we have to remember, for example, the history of Orkambi, lumacaftor, ivacaftor, which had respiratory adverse effects, and then tezacaftor, ivacaftor didn't have these respiratory adverse effects, and this is why it was chosen for being the basis of the triple combination therapy. So some of the adverse effects may be really related to the molecules rather than the CFTR restoration of CFTR function.
Thank you very much. And just one final word on this. A very practical thing that CF teams should do and must do is ensure that everybody in the team is being consistent, and that nobody's going up to these families and saying, "Why are you not on a modulator?" Because that really upsets them. So it's not easy to do that, because you can always have a new member of the team or a junior doctor or whatever going, why are you not on modulator therapy? And we must not do that, but we mustn't be the elephant in the room as well, as you say, Eddie. We need to. This is a subject you can't just put it under the carpet, as we say in the UK. You need to be open and remain hopeful. So that takes us on nicely to the next section, Eddie, around supporting mental and emotional well-being. And we did wonder about putting this section into paper 2 on establishing and maintaining health, but we actually felt that the challenges that people with CF face from a mental health and an emotional perspective are really unique and challenging. And we felt actually it sat quite well in this paper. I don't know if that panned out quite as you were hoping, but
I think also you'll see it in paper 4 as well. I think there's an underlying, of course I'd say this as a psychologist, but of mental health throughout all the papers. And I think that's what's so exciting, enjoyable, challenging working in the CF field and with doctors and other health professionals, because I think everybody is very psychologically minded, and it's working with a team together. And particularly now, you have a whole life journey, right from diagnosis to try and help cope, help parents cope with a new diagnosis, especially with newborn screening. We've discussed SPID as well, which is the uncertainty, through to schooling, career, family planning, which now has changed, longer life, treatment adherence have changed completely. There are some patients who are doing way less because of the modulators. There are some doing way more because they can't be on the modulators. So one has to be constantly on your toes. And I and the team I work with very much believe in working together. It's like a baton, you pass on the baton. We recently, for example, had a 14-year-old patient who'd been diagnosed with diabetes. She was telling me what she was not doing, which then I could then relate to the dietitian, who could then relate to the doctor. So you work together and hold the patient to see where they're at. And I think that it's really important to have communication, a trusting relationship, and to enable the patient to understand as much as possible about what's going on with them in their body. Because I think sometimes we assume they know more than they do, and it's very important to constantly check on that with the education. There's a mnemonic that I thought of, EPSI, which is education, prevention, screening, intervention. And I think that's something that can be integrated for the whole team and not just for the psychologist. EPSI.
That's very nice mnemonic, Eddie, but not actually a word. But
no, is it mnemonic? No, it's not a word. I just thought.
So I mean, it's really, in my mind, I've always felt this, and I've enjoyed very much your input into these papers. But the psychologist is embedded within the CF team, because many people with CF and their families are really resilient and really, strong during very difficult periods, but actually all of them need to have that support available and a recognition of mechanisms that you can support them with in coping. So I thought it was a really lovely section, and thank you for providing it. Yeah.
I just want to add, I feel that because it's long-term ongoing care, the CF team is seen as an extended family for these patients. It's a privilege actually to work with CF patients, because you accompany them along the road of their lives in different junctures of their life, which I think is very supportive for them and for us as well.
Well, I think that takes us on. Oh, Peter, we'll move back to Peter. Yeah.
I was just going to very much support Eddie's comments. The difficulty is these people have often gone from being told they really have a shortened life and they don't need to worry about schooling or university or whatever, to now, with modulators especially, they could have an almost normal life. So they've had huge changes just over a matter of 20 years. And that really would be a huge psychological stress, almost like being told you've got breast cancer and, oh no, you haven't got breast cancer, it's all okay now.
I think there's two points here. It's what do I do with the life that I missed out of? And then, what am I going to do now with my life? And added time to my life, which can be scary as well. And quite a lot of expectations. Who am I? Who am I if I don't only focus on my CF? So I think it is a huge area within itself.
Absolutely. One of our patients actually said that she'd actually lost her identity because she was the sick child in the family, and now she's not the sick child. So what does she do? What does she represent? And that's actually quite an interesting concept.
We had one patient who went into depression and nobody could understand it. But what's wrong? You feel better. But I think it is important I agree with you, Peter, to be aware of that aspect as well, and to allow patients to discuss even their fears of living a full life.
But I think we need to be very careful though around, and it comes back to this point of celebrating transformation, but actually this is a different journey. This perception that you no longer that you're, as Peter said, normal. I don't quite like that expression, because are any of us normal? This could be a perception of somebody who's got an FEV1 of 65%, and they say, "Oh, my life is transformed," and you just need to rein them people in a bit and sort of keep their feet on the ground. And it's difficult to do that without being like a bit of a party pooper from the benefit that they're feeling. It's a really difficult balance, for CF teams, and we'll see how things evolve over the next decade, really. And that brings us on really nicely to the last section, which we'll cover very briefly, around when life gets challenging. And we've had this, what people have described as a honeymoon period, people with really advanced CF lung disease and CF disease who were possibly on a transplant waiting list, coming off that list once they've been established on modulator therapy. And obviously we have the people who are not eligible or not responsive, to modulator therapy, who are still facing these challenges. And I think there's a really nice section, some great authors around supporting the complexity of the increased treatment burden, supporting the extra nutritional support, building on what was in the last paper, and then a really nice section from Whitney Brown, Amanda Piper, and Charlotte Addy on supporting breathing and the appropriate timescale of intervening on that front. And I'm afraid, haven't really got time to go through all those, but I recommend those sections to you. But I did want to talk briefly, Pierre-Regis, around transplantation. Obviously, numbers of people with CF moving towards solid organ transplantation, lung transplantation, reduced dramatically following the introduction of CFTR modulator therapy. But it's still happening, and it's still important that intervention, that working with those transplant teams is open and accessible as we move forward.
Absolutely, I fully agree with you. It's really important to maintain transplantation expertise and capacity to perform transplantation and to follow post-transplant patients. One of the things is that everything that we wrote in this manuscript, in this standard of care, was based on years and years of expertise that was obtained before modulators. And we know that modulators are changing the problem, that a lot less patients go to transplant, even though some still are going to transplant. But one of the questions you were mentioning, the standard of care in 10 years, is how do we maintain this expertise? In France, we used to transplant 80 people per year for lung transplantation for CF. Now it's less than 8 per year within the past 4 years. So maintaining expertise is really difficult, not only talking about post-transplant care, but also referral to transplantation, when to talk about transplant in patients with modulators. All these questions we don't really know about. And
timing is really difficult now, Pierre-Regis, because it's completely changed the playing field for this in this area. I think that's very challenging. But that partnership working between the CF team and the transplant team is essential, and it needs to carry on. There's a degree in the UK of variance in post-transplant care, which is not ideal, but is understandable. I think in France you have a much more systematic sort of approach to post-transplant care, and your transplant service is renowned across the world, really.
Well, the thing is that, as you know, there are different models of follow-up of post-transplant patients. And in France, the transplant units are usually also the CF centers. So it may be a different unit, but in the same department. So the doctors are doing both transplant and CF, so they're not completely different teams. They are located at the same hospital within the same department, and it makes things much more easier.
Yep. Yep. So that's a very useful section, and that then brings us on to the final section, which is a difficult section, but is really brilliantly written by Sue Madge and Felicity Finlayson, Eddie, which reflects on support in planning for end of life, and again, as Pierre Regis highlighted, now in the post-modulator age, that's even more challenging for the CF team. And when do you have that conversation, and when do you open things up? And I think this section reflects a lot of previous work that Sue and others have done in this area. But I think it's really nice saying that we need to be sensitive, we need to be consistent as a CF team, but we need to be open, and we need to be enabling these people to go on a journey, but it's a very individualized journey. It depends on where they want to go, how fast they want to go, and the things that they want to do. Each person is different and needs to be respected, and we have to use our palliative care colleagues in a proactive way to sort of support that journey, particularly as this is something that we hopefully and thankfully will be dealing with less and less over the next 5 to 10 years.
Just to say, very quickly, I know time's running out, just to also not run away from the very, very difficult questions and issues, the reality that is raised. And we've had many patients who know that they are going to die, and what has really helped them is planning for their death, which means having closure, writing to their families, having family therapy sessions with their family, planning on how they want to die, where they want to die, pain, how to control it, because I think it gives them a sense of not only closure but also control and empowerment. And as you said, Kevin, everyone's got their own way of wanting to do it, and it's very important to listen. But I do think it's important not to run away from the harsh reality of how they see ending their life and closing, having closure with the ones they love.
Absolutely, and that this is a process, and you embarking on a process with them, and it's not just a one-off, like, hour meeting, where it's a process that takes time and goes at different paces. So that's a slightly somber but topic on which to finish, but a really important one and a really good one. And next week will be slightly more optimistically looking at planning for a longer life. But before next week, I'd like to thank again Helen Chadwick from the ECFS education platform, who has been tremendously helpful in helping us to organize this. And the webinars are on that platform if you want to see my ugly mug and the more attractive colleagues who have joined me. Or you can listen to them as a podcast, which I recommend if you're maybe not cycling or walking the dog or anything. You can listen to these podcasts as a way of embellishing the papers that hopefully you will have read. And finally, to thank my three colleagues, Pierre Regis, Peter on the other side of the planet, who can go to bed now, and Eddie for their contribution today. So all the very best, everybody, and thank you for joining us.
Thank you.
Thank you.